Welcome to the TMIT National Research Testbed High Performer webinar series, webinar number 125. We'll be covering the 5 rights of pain care, opioids and diversion update, and a mass casualty update from our leaders at MD Anderson Hospital we're on right now. So I am Charles Denham. I am going to be the MC for this program today, and it's our 125th month in a row. So we're a few months into our second decade, and very blessed to be reaching out to you again today. Couple of housekeeping details. I'm on slide number 3. Please turn up the volume of your computer, your speakers, and your WebEx volume. If you don't have enough volume and the quality is not good enough, then what we'd like you to do is to click on the panelist section and request the phone icon in the lower right-hand corner of the panel, which you'll see on slide number 4 for those that have the slides, and go ahead and request a phone line. I am now on slide 5, and it shows the landing page for www.safetyleaders.org. If you go to the upcoming events panel in the upper right quadrant of the landing page, you can click on this webinar and go to the slides. If you're watching on demand and online at a later date, you'll be able to go and collect resources which we'll continue to update, which will take you to the page that you see now on page number 6. So slide number 6 will be the landing page for this particular webinar. You'll be able to watch it unlimited times, and also be able to collect resources that we'll post there that will be added. And the slides, if they are updated, will be there, and the current set of slides are there now. Our social media addresses are on slide number 7. On slide number 8, our purpose statement, which we take pretty seriously, is we will measure our success by how we protect and enrich the lives of families and patients and their caregivers. So this is both for families, patients, and their caregivers, and the topics today cover both of them in a very detailed way and a critical way. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve and the ventures that we undertake. I won't read the disclosure statement, which is on slide 9, but no pharmaceutical product nor technology product is covered in this webinar in any way, and no service offering as well. Our speakers today, we have Dr. Gladstone McDowell, who is multi-board certified pain management specialist, as well as a urologist, urologic oncologist, and anesthesiologist. Kimberly New, who's also spoken to us numerous times about drug diversion, will give us an update on that. David Marx, the founder of the Just Culture movement and the program that all of us use in terms of just culture, will give us an update on the Vanderbilt case as it's evolving. And we're delighted to have Dr. Gregory Botz, who is a leader at MD Anderson in critical care, a co-founder of our Med Tac program, along with Bill Adcox, who is the Chief Security Officer, Chief of Police at the University of Texas Health Science Center and MD Anderson Cancer Institute, or Cancer Center. And we have Jennifer Denham, who is our voice of the patient. So we first, before we get started, always want to hear our voice from the patient to kind of set our compass properly. And Jennifer Denham has been a long-standing patient advocate, a terrific contributor to multiple areas of patient safety, having served on multiple agency boards. She worked with me on the National Quality Forum Safe Practices updates, and was one of the leads on the program that we put together to help support the hospital-acquired conditions program, which now we're so blessed to know has saved more than 8,000 lives and $2.9 billion. And without the patient advocates on the team, this would have been entirely impossible. So we're so blessed to have Jennifer join us today and set our compass.
Thank you, Dr. Denham. It's a pleasure to be here with everyone today. This is a really exciting webinar, and I'm looking forward to it. This is such an important issue. Pain, it's just incredible, and the opioid issue in the crisis in this country is something. I just encourage everyone here to please, invite your friends to listen to the recording of this. This is very important work. And again, thank you so much for being here. I'll turn it back over to you, Dr. Denham.
Thank you so much, Jennifer. So what I'm going to do is move very rapidly through an In the News update and recap the survey from our last webinar because we listened to this audience. It's about 25,000 members. It's the world's largest patient safety community of practice. And we pull you constantly, as you know, to get the best ideas and find out what's keeping you up at night and the help that you need. So very rapidly through the news, probably very appropriate for us to make sure that we're aware of the recent bust occurring yesterday. And we always try to be timely for you because we know a lot of you use these resources for briefing your teams across and we have about 3,100 hospitals in our network, so we know a lot of you are doing the briefings of your teams. Read up on the bust that occurred yesterday. It shows the Department of Justice is really focused on the opioid crisis, and we have a number of our colleagues that are making some serious mistakes in ethics in terms of prescribing these drugs, and a really terrible story, and very important for us to realize that this can happen in any community. Also, an excellent article in the New England Journal of Medicine in the last 2 weeks addressing the Purdue Pharma focus on, and the title is Preying on Prescribers and Their Patients, Pharmaceutical Marketing, Iatrogenic Epidemics, and the Slackler Legacy. I think it's a very good cautionary tale, important article to read. New England Journal of Medicine, as we all know, is an excellent resource, well-written article, and Dr. McDowell will allude to the notion that we had of the fifth vital sign, which you see in the first column, and the fact that a lot of the education was focused on things that now we probably do not find to be entirely accurate. NPR also addressed the $270 million opioid settlement in Oklahoma, and that this is the first of as many as 1,600 lawsuits focused on this. This is critical because this is such an important issue, but we also know that this kind of thing can be occurring in other areas of pharma. That brings us to the continuous coverage of the Johns Hopkins patient safety issues. Another article just came out in the last 2 weeks regarding the families, and we know that we always want to engage patients and families after an accident, medical error, a problem in the hospital, and there is such a polarizing energy in the community with what's happened in the community in Florida at Johns Hopkins All Children's Hospital, where 1 in 10 children died actually undergoing cardiothoracic surgery, that many of the families are resistant. So this really is an important story to continue to follow. And as you know, some of the most important ones regarding patient safety that are important to us, and there are more than 25 articles now written by Tampa Bay Times. You'll find in a moment that the two authors had done a terrific job of investigative reporting and were finalists for the Pulitzer Prize. Critical, if you haven't read these, we don't want to belabor them. We've covered them in our last webinars, but in the resources section of this set of slides, you can go and look at the entire list of articles that were written. Yesterday, or the last 2 days, the Pulitzer Prize finalists were announced, and the two authors on these articles were finalists for the Pulitzer Prize. We found them really to be very factual and not over the top. And again, there's so much that we can learn from these articles. We've also been following a number of articles regarding a number of our top medical centers regarding conflicts of interest. So the Johns Hopkins story addressed the deaths of 1 in 10 children undergoing CV surgery in Florida, but all of the Johns Hopkins hospitals were implicated in patient safety issues, retaliation against a leader who was bringing up problems with the Burn Center, whistleblower suit, and just a number of cautionary tales, more than one, that we really need to listen to. The others are Memorial Sloan Kettering, Baylor St. Luke's Medical Center, the Brigham and Women's Hospital, and Vanderbilt University, many leading to retractions of articles for what the Government Office of Integrity would say is fraud, which is falsification, fabrication, and there was not much plagiarism in these. These are pretty overt conflict of interest issues that can impact everyone. Duke University is one of the more recent ones, $112 million lawsuit, and something really we really need to be able to understand, and we'll ask Chief Adcox perhaps to mention how important this threat is as one of the top leaders in threat safety science. And then yesterday, the announcement that that the bills are being signed into law on the University of Maryland issue that pertains to board behaviors. So a number of these articles are in the resources section. I don't want to belabor them. I'm 10 minutes after the hour now and on time, and I'd like to get to our main speakers. I want to remind us, though, about the letter that went out from the Health and Human Services regarding conflicts of interest. And if you're at a major medical center, almost every major medical center receives such a letter regarding conflicts of interest of their researchers. This is critical for our young faculty to understand how absolutely necessary full transparency is, and not to be, if you're going to be a full-time academic, critical to keep a very clean conflict of interest position. The article about Duke, I won't read it for you, it was on March 26th. And again, an excellent factual article that gives us some insights as to how organizations might behave after there is a problem, and whether they should come clean early or if information is suppressed. Also in the story on Memorial Sloan Kettering, there continue to be articles. I think the takeaway here is that if there are these problems, they're going to be, just in this internet age, are going to become told very widely, and it's so critical that we focus on them. In a few minutes, we'll have David Marx address the issue from a just culture perspective of the nurse that was prosecuted for the fatal medical mistake. You see it here, and we've covered it, and I won't belabor it. I just want you to know that there are additional articles you can pull, and we'll let David comment on the case. Another fraud issue that popped up over the last month that is just shocking is the fraud and deception that is occurring in residency applications for matching, which was just it almost takes your breath away that these medical students would risk their entire careers by fabricating information in their competition for residencies. And so critical to be aware of that if you're at an organization where you have residents applying for or medical students applying for residency. We had a president of one of the major universities here visiting with us last week, and this was just took everybody's breath away, because no one thought that would be happening. I guess very much like what has happened in colleges and the scandals that have occurred with bribery to get kids into college. So I'll finish up with just a quick update on the Med Tac Global certification course for bystander care, and just really honored to have Dr. Gregory Botz and Chief Adcox with us today, who are co-leaders of this program with us, and remind you that Campus Safety Magazine, 2 feature articles on that if you aren't aware of this, and this is focused on the first 3 minutes or in the first 10 minutes before EMS arrives. What can bystanders do? What can we do to train them, and how we as caregivers can train our communities, and the terrific impact they can have. We have a series of YouTube videos. I just want to remind you that they're in the slide deck here on these topics. And that brings us to in the news regarding these mass casualty events. It's now we're approaching the 20th anniversary of the Columbine massacre, and we all heard what happened in the news here recently. This is why our teams in Med Tac are so focused on the Stop the Bleed program and what to do to train bystanders to be able to prevent really be able to prevent death and harm over time. And Dr. Botz and Chief Adcox will address the autopsy findings of recent events that really underscore the importance of bystander care. It's terrible to see that these awful things are happening in other countries. In our Med Tac program, we're taking globally, and we'll be collaborating with the World Health Organization to get this information across multiple areas. And then the last in the news was just heartbreaking. to hear of one of the topical areas we focus on in Med Tac is anaphylaxis, and to hear of this little girl who died using toothpaste that had some milk-based substances in them and died of anaphylaxis. So these leading causes of death are absolutely critical. Finally, Captain Sully Sullenberger, who is in our second discovery film, Surfing the Healthcare Tsunami, was just a great contributor to it, and I think there's a lot to be learned from how an organization like Boeing is dealing with an incident and what led to that. So that's enough for In the News. I'm right on time at 50 minutes after the hour. I'll finish up by giving you just an update from our webinar with Tom Vanderwark, who covered governance issues. He actually earned a 100% Net Promoter Score, so we know that he really hit the topical areas. 82% agreed that they'd like to have more governance board issues. Are you interested in a webinar regarding infection control issues? And we had 34% give it a 10. Interestingly, 6% 9, but we still have a strong agreement. So this year we'll continue to address sepsis and a number of infection control issues. The topics that you all picked in terms of free text entry are included on slide number 39 for your reference to go back. We asked the audience last month how much interest there would be in pain management and the opioid issues, and you gave that a very high number. 48% gave it a 10, 10% gave it 9% gave it a 10, and you can see that pretty strong agreement, although there were some that were not that interested. So we're covering it today as an update because we've covered this in multiple webinars before. The topics on slide 41 are those that you brought up. And then mortality reviews we will have covered next month. So our partner and collaborator at the Mayo Clinic, who has really pioneered mortality reviews, which we believe is probably the next biggest breakthrough in patient safety, will be led by Jean Huddleston again. And she has had rave reviews, really digs into errors not only of commission, but the 80% of the harm that were contributing to deaths at the Mayo Clinic were errors of omission, and she'll give us an update on that. We just wanted to be able to feed her information regarding what you were interested in. So that brings us to Dr. Gladstone McDowell, who I have known for almost 30 years. We both practiced in Texas. He is as a urologic oncologist. I was a radiation oncologist, subspecialized in brachytherapy and the urologic illnesses, and he and I both trained at MD Anderson after we finished our initial training in our specialties. Boarded in 4 specialties, Dr. McDowell actually does a lot of teaching of residents and of medical centers because of his surgical strength and his ability to kind of grasp not only all areas of pain, but especially some of the chronic pain issues and those that come from cancer. So it's a real delight to have Dr. McDowell speaking to us today. I developed a framework called the 5 Rights. We've applied it to emergency care. Then we applied it to pain management, and he and I collaborated on what you'll hear him address in the 5 Rights of Pain Management. And then he'll follow up with addressing the opioid crisis and what the updates there are from the CDC.
Thank you, Dr. Denham. Good afternoon. I'm going to discuss the 5 Rights of Pain Management. I run a multimodal practice in Columbus, Ohio. I've had the pleasure of working with the TMIT group for a long period of time. I would like to move to the slide that describes 5 rights of pain care. As you can see, as we move through this in a clockwise manner, we're discussing the right tests, the right diagnosis, the right treatment, the right monitoring, and the right prevention. This is a very good reconciling structure when we sit and decide how to evaluate, make decisions, and perform treatment for our patients. I'd like to break this down by going to the next slide, which shows the right tests. So caregivers and patients need to make sure that the right tests are undertaken to make the right diagnosis of the sources of pain. What we know is that pain is a subjective complaint, and pain may be influenced by age, gender, culture. Some patients may have better communication or language skills than others, previous experience, anxiety, and very importantly, genetics really affects this. And so when we sit and think about the right tests, we need to think, well, what what is the pain generator for this patient? The most important thing is a history and physical, but good supporting info is obtaining imaging, and this can be in the form of plain x-rays, MRI with or without contrast. With contrast, if you're dealing with somebody with a potential cancer diagnosis or somebody who has had spine surgery, CAT scans, ultrasounds, bone scans, and sometimes a combination of these may be necessary. We also like to draw lab work because I find it very important to identify whether somebody is deficient in vitamin D. We'd like to know about your renal and hepatic function because we can make decisions upon what types of medicines to treat people with. And then very importantly, particularly in this day and age, we look at the urine drug screen, but we also want to look at the pharmacogenomics because there are several ways that genetics can influence the analgesic response. There's drug metabolism enzymes, there are drug transporters. Some opioids or other pain medicines may have receptors that we need to be cognizant of. And then there are structures involved in the perception and processing of pain, and pharmacogenomics can sometimes help us when we're making decisions about this. We move to the next slide, which talks about the right diagnosis. And again, we need to really look at this in a very thoughtful manner. So pain has causes requiring a thoughtful approach to understanding the pain generator in order to undertake the right treatment. If I think back to my fellowship at that point in time, we were focused on the right diagnosis. But we used medicines that would treat a global pain, a global pain type. And often we bound to the mu receptor here because we thought that, well, opioids are good. There's no ceiling effect for opioids, and we now know that this was perhaps we had inadequate information here. We were making decisions based upon inadequate data. And now we'd like to find the pain generator so that we can select the correct treatment for patients and utilize it at the right time. We go to the next slide, which discusses the right treatment. So optimal pain relief often requires an integrated strategy of multiple tactics. So the right combination with a team-based approach has enormous potential. So I, as a pain medicine physician, will utilize comprehensive medical management, and that's non-opioids, or properly selected opioids at correct doses, utilized for the right diagnosis at the right time. But we also use physical therapy, acupuncture, work with chiropractors. We believe in movement as a critical part in treating patients with chronic pain. We utilize things like water aerobics, yoga, a variety of strategies like this. And so the important thing is to figure out the right treatment for patients. We no longer move to opioids as the first form of treatment or even the second. I will often say to a patient, the opioids would be the very last thing that I would consider for you. We utilize, besides the comprehensive medical management and the physical therapy aspects, we use minimally invasive injection treatment, spinal cord stimulation or peripheral nerve stimulation when appropriate, targeted drug delivery in forms of intrathecal therapy with non-opioids or opioids is perhaps an unrecognized and underappreciated aspect of pain control for people with advanced pain that has failed maximum medical therapy or properly delivered minimal interventional therapy. This can often keep people from having surgery if it is not absolutely necessary. So again, the right combination with a team-based approach has enormous potential. We move to the next slide. We talk about the right monitoring. When caregivers, patients, and families record the impact of pain care, the tactics can be fine-tuned to the patient and an integrated approach can be taken. We now know that in the past, we perhaps have not monitored patients as well as necessary. What is crucial now is to obtain a baseline urine drug screen on patients. I like to obtain lab work, again, a comprehensive metabolic panel, a CBC. I'd like to know what their vitamin D is. I will often check the testosterone and estradiol on patients. So we use all of these things, and then as we treat people, we would like to monitor their response to treatment. We'd also like to make sure that people are being compliant with the medications that we're treating them with. And the whole concept of universal precautions is really important here. So we screen and treat everyone. We provide pain agreements, and we hold people to these. We also hold ourselves to performing the aspect of it that we have committed to. So I think it's important that monitoring can really help you to know whether you're doing the right job for the patient, but also help us to be able to change the directions whenever we feel that we're not progressing as we felt that we would. And then prevention. So certain pain scenarios are related to what patients are doing in their daily lives. For instance, back pain can be impacted by safer ways of doing work. And exercise can strengthen muscular support and a reduction in pain generation. I've often found that many of my patients who have sedentary jobs, they sit in a very low, comfortable chair, and they don't get up very often. I encourage patients now to use the sit-stand desks, or perhaps to find a working station. But to get up every hour and move around, do stretching. I think many workplaces now have incorporated yoga and stretching into the workplace in an effort to prevent some of these neck and back-related injuries that people complain of. And most of these are musculoskeletal, and most of these can be prevented. We also work with physical therapy and the other consultants in an injury prevention mode, so that I will say to patients, now that I've treated you and we've returned you to work, let's try to avoid things that got us in trouble in the first place. If you move to the next slide, we talk about some of the frequency of pain. We now know that pain is the most common thing that people present to their primary care physician. We spend an incredible amount of money on this problem in this country in terms of evaluation, treatment, but also lost work days and then disability payments. If we move to the next slide, when screening patients and thinking about do we have the right diagnosis, we need a baseline pain score from them. There is the numeric pain rating scale that goes from 0 to 10. This is an 11-point scale, 0 being no pain, 5 being medium pain, 10 being the worst possible pain. We like to obtain a baseline pain score for people. If they don't speak your language, or they may be a child, there are Wong-Baker scale that can be utilized for them. When we talk about the right tests, I've talked about some of these before, but it's important to make sure that we really sit down and discuss the problem with patients and come up with a strategy to try to obtain some objective data by which to make decisions on how to make treatment decisions for this subjective complaint. And then we want to monitor outcomes so that we can change our treatment and change our strategies depending upon how patients do. The slide that shows the balance of over-medication versus under-medication, this really pertains primarily to opioids. If opioids are being used, short-acting opioids should be the thing that you start with. Short-acting opioids are typically only meant to be used for acute pain. They should be used potentially for breakthrough pain. You never start somebody on a long-acting opioid. If you started them on a short-acting opioid and the pain persists over a month and it becomes a chronic condition, you then may want to transition to a long-acting opioid while utilizing a very limited amount of short-acting opioids for dosage finding. And then in my practice, we tend to get rid of the short-acting opioids and maintain people, when necessary, on longer-acting opioids, but at judicious doses and with proper monitoring. If we move to the slide that describes the guidelines for prescribing opioids for chronic pain, if you look at the CDC came out with strategies and a document several years ago. And this was primarily to help primary care physicians decide when to initiate or continue opioids for chronic pain. They commented that opioids should not be the first line for chronic pain. And again, I think that in the past, people have defaulted to this because it tends to be easy and this tends to be what patients want. But the CDC came up with guidelines to help primary care physicians. Now, importantly, this did not exclude cancer patients or patients who have terminal conditions from obtaining opioids. But this establishes and gets you to measure goals for pain and to measure function when you make decisions about increasing or decreasing doses. And this helps to provide a guideline to discuss the benefits and risks and availability of non-opioid therapies with patients. The FDA came out and also supported this particular strategy. In looking at opioid selection, dosage, duration, follow-up, and discontinuation, as I said, use immediate release opioids when starting, recognizing that these should not be used for a long period of time and certainly not to treat chronic pain. As with everything that we do in medicine, you start low and go slow. You base your changes on how the patient is doing. I like to see my patients. I like to look at them. I like to examine them and look at their lab work and make decisions about when to titrate up or down. Gone are the days when we call medications in. And I think that there's actually a benefit to this because it can help us titrate in a more safe manner. When opioids are needed for acute pain, prescribed no more than needed. I think in the past, physicians got in trouble because they prescribed large doses and patients use a small amount of them, a small dose or a small quantity, and then had medication sitting around that could be diverted or potentially abused at a later date. And again, recognizing that we do not prescribe extended release or long-acting opioids for acute pain. So follow your patients, reevaluate them for risk or harm, reduce the dose or taper or discontinue as needed. And this takes us back to our right monitoring. So again, by monitoring the patients, we can fine-tune our tactics based upon the patient and move forward with our integrated approach. The CDC document describes assessing risk and addressing harm of opioid use. And again, this supports the use of urine drug screens as obtaining a baseline and then monitoring them at certain intervals. We tend to obtain a urine drug screen at least 4 times a year, or perhaps more for people who are in a more high-risk category. We tend to utilize all the data at our disposal to place people in a low, medium, or high risk profile and then monitor them based upon that. So evaluate risk factors for opioid-related harm. Check your prescription monitoring program for high doses or multiple prescriptions from other providers. And then utilize your urine drug testing to identify whether the patient is taking the substances that you have prescribed or whether they are utilizing undisclosed medications or perhaps illicit substances. Very important, you'd like to avoid the concurrent use of benzodiazepines with opioids. Greater than 30% of overdoses involving opioids also involve benzodiazepines. Benzos tend to work to calm or sedate patients by raising the level of the inhibitor and neurotransmitter GABA in the brain. The problem is that many common benzodiazepines, including diazepam, which is Valium, or Xanax or clonazepam, have been used for a long period of time, and they have not been monitored. Now it's estimated that 30% of these overdoses involve benzodiazepines, and we do not prescribe benzodiazepines with opioids if at all possible. recognize that zolpidem, which is Ambien, is now a street drug. It goes by a variety of different names, but it's estimated that 500,000 people are abusing Ambien here and other sedatives. Arrange treatment for opioid disorder if need be, and this is something that we certainly hope we will see better support from in terms of payment for treatment plans. In monitoring, we know that people who are on opioids become tolerant to most of the effects of it except for constipation, and you need to be proactive in treating them. But again, if you look at short-acting opioids, you see that there are high doses and then the dosage drops, but you have this picket fence phenomena. We'd like to pick a appropriate medication, and if people need an opioid, to find a long-acting opioid that will remain within that therapeutic window, giving us a proper balance of safety and efficacy. In terms of a checklist on the next slide for prescribing opioids for chronic pain, these are some of the things that we consider when looking at long-term opioid therapy. And, you have to see the patient, you have to examine the patient, you have to put together all the data that you have accumulated, then make the decision about whether a patient is appropriate for opioids. Set realistic goals for pain and function based upon their diagnosis. I like to pick at least 2 goals that we want to achieve, and then try to hit those, and then perhaps change the goal as people have improved function. And then I need to set criteria for stopping or continuing opioids. And again, it's hard to do this unless you see the person on a frequent interval. So we see patients who are on opioids monthly. We reassess them at each return visit. We just don't write a prescription. In many states, there are limits in terms of the mean morphine equivalents. We would like to avoid greater than 90 mean morphine equivalents a day, particularly for patients who have a non-malignant diagnosis. And in our practice and in many practices, we prescribe naloxone for all patients who are at or above 50 mean morphine equivalents. The next slide just indicates to you that, in terms of treating and monitoring patients, nothing is perfect. We don't know how many physical therapy sessions are necessary for every chronic pain condition. We don't know how many injections. There is a debate upon which medications are best in terms of oral medicines here. Surgery, not everybody is a candidate for surgery. Many people have surgery. Some people do well. Some people don't do well. People can be rescued with spinal cord stimulation, or they can have spinal cord stimulation as an alternative to a open surgical procedure. And then again, targeted drug delivery, which is the implanted drug pump, traditionally was left to the very end. We have now moved spinal cord stimulation and targeted drug delivery in many cases above high-dose, long-acting opioids for certain selected patients. I would certainly consider those for my younger patients who have perhaps a spine-related disorder or a peripheral nerve injury before putting them on a particularly addictive controlled substance. And we've talked about the prevention, making sure to look at the person's workplace, monitoring their ergonomics, and making recommendations, getting occupational assessments for them. And then if you look at the slide that describes the domains of pain, this is why we want to make sure that we are following the 5 rights of pain, because we owe it to our patients to try to enable them to return to a quality, functional existence. We know that chronic pain, inadequately treated, unrecognized, and not followed properly, can affect your physical functioning, reduce your ability to perform your activities of daily living. You can't work. You have difficulty doing the things that are recreational activities that give you pleasure. 50% or greater of pain patients are depressed. There's anxiety, there's anger, there's sleep disturbance, which makes your depression worse. You lose your self-esteem, particularly if you can't work, you can't perform the recreational functions. Then you move into these socio-economic consequences here where you miss work, there's disability, lost work days. All of these tie into the social consequences of depression, anxiety, sexual dysfunction, intimacy dysfunction, isolation here, affecting your family and your marital relationships. And so I think it's important that we really recognize these in treating our patients and coming up with strategies to provide the right treatment at the right time. The next slide describes the triple threat. And, you know, we put this in there to really highlight the fact that when the emergency hospitalizations for adverse drug events were looked at between 2007 and 2009, you know, oral antiplatelet agents, oral hypoglycemic agents, and opioid analgesics were implicated in 67% of all hospital admissions. Now I'll spend a few minutes on the opioid crisis, adverse drug events, and opioid overdose deaths. The AHS priorities in the opioid crisis. In response to the opioid crisis, the U.S. Department of Health and Human Services is focusing on 5 major priorities. Number 1, improving access to treatment and recovery services. Number 2, promoting use of overdose reversing drugs. Number 3, strengthening our understanding of the epidemics through better public health surveillance. Number 4, providing support for cutting-edge research on pain and addiction. And number 5, advancing better practices for pain management. You know, if you look at the triple threat in just reviewing the emergency hospitalization for adverse drug events in older Americans, published in the New England of Journal in 2011, where they reviewed the statistics from 2007 to 2009, oral antiplatelet agents, oral hypoglycemic agents, and opioid analgesics were implicated in 67% of emergency hospitalizations. You look at the Office of Disease Prevention and Health Promotion, again, when you're looking at the high impact preventable ADEs, adverse drug events, opioids and benzodiazepines are common, they're clinically significant, and they are preventable. We've talked a little bit about this, but the next slide describes where the adverse drug events occur versus errors. I won't take time going through this slide, but I think it's important that you recognize that there's a history taking, there's ordering, the medication inventory management, surveillance, pharmacy management, and the whole administrative management. There are multiple areas here for errors versus adverse drug events. I'd like to move to the next slide where we talk a little bit about the opioid crisis. We know that the United States has 4.6% of the world's population, but we provide 99% of the hydrocodone. We know that nearly 3 out of 4 people who misuse pain medications obtain the medication that's prescribed for someone else. As I said in the past, we did not know that much about addiction medicine. We did not know that much about aberrant behavior. And in our physician effort to treat pain, people were prescribed opioids. Now we're finding that there's a huge diversion problem as the restrictions suggested by the FDA and the CDC were put into effect and physicians stopped prescribing as many opioids. Some patients, unfortunately, move to heroin as a cheaper, more accessible way to treat their pain. We know that heroin use is part of the largest substance abuse problem. Nearly all people who use heroin also use at least one other drug. Most have used at least 3 other drugs. And you can see here that people who are addicted to alcohol, marijuana, cocaine, and opioids are more likely to become addicted to heroin. This is a very good slide that basically summarizes the CDC data. If you look at the 3 waves of the rise in opioid overdose deaths, the important thing is recognizing that the first wave began with increasing prescribing of opioids in the 1990s. And this was sort of when the first long-acting opioids came out, and we were encouraged to use them for chronic pain without a lot of data supporting the fact that they were effective for everybody with chronic pain. The second wave began in 2010 with a rapid increase in overdose deaths involving heroin. The third wave began in 2013 with significant increases in overdose deaths involving synthetic opioids, particularly those involving the illicitly manufactured fentanyl. So the IMF market continues to change, but can be found in combination with heroin, counterfeit pills, and cocaine. If you look at the next slide, it describes the three waves again, but also the opioid epidemic by numbers. We see that 116 people died every day from opioid-related drug overdose deaths. 11.5 million people misuse prescribed opioids, and this is really in line with what we've talked about before. On the next slide that describes the overdose comparison, you can see here that an extremely low volume of fentanyl on carfentanil are required for life-threatening overdose. This poses an enormous threat to the public and caregivers. I would like to interject something here that just recently China announced earlier this week that it would ban all variants of the powerful opioid fentanyl. This is a move that could slow the supply of drugs that in recent years has caused tens of thousands of overdose deaths here. This is a promise that the Chinese leader, Xi Jinping, made to President Trump last year, and it appears that they're actually intending to act on it. The next slide from the NBSS shows the percent change in drug overdose deaths between the 12 months described here. We look at the National Drug Control Policy and their safety recommendations for first responders. We know that first responders in their effort to help patients have sometimes been affected when they have come in contact with fentanyl, either topically or through the inhalational route. And there are recommendations now for gloves and specific masks to protect these people. The next slide demonstrates the CNN report of fentanyl deaths skyrocketing more than 1,000% over 6 years in the U.S. And the researchers who are part of the National Center for Health Statistics showed that by 2016, the rate of men dying from fentanyl overdoses was nearly 3 times that of women. Americans are now more likely to die from a drug overdose than a car accident. In 2017, drug overdoses killed more than 70,000 Americans, and opioids are the leading driver in U.S. drug overdose deaths. If we move to the next slide, the important thing here is that we talk about strategies to try to prevent some of these deaths. We know that naloxone, the potent reversal agent, can be very effective. The Trump administration vows to work closely with law enforcement to help combat the opioid epidemic, including expanding access to drugs such as naloxone that can help reverse the opioid overdose. You can see here, you can read about the law enforcement naloxone toolkit. I think this is a very important thing for them to have. The next slide just describes the fact that understanding the naloxone standing orders is vital. There are 42 states and the District of Columbia that have enacted standing orders to make naloxone available without a prescription. Many pharmacists are still unaware of these orders. I think we have a lot of work to do here in terms of educating the public and families and even school children on efforts that can save lives. The next slide shows a report from USA Today. The Surgeon General says to save lives, we need to have the opioid antidote naloxone. It describes what needs to be done. People at risk should keep the antidote on hand. As I said, 41 states have legalized it. There's still several states that have not done this, but on April the 5th, he recommended that more people should carry the antidote for opioid overdose. And here, the last slide, a report from USA Today, just reinforces that the Surgeon General says that people need to have the opioid antidote naloxone available. We've talked about the fact that several states have legalized it without a prescription, but we still have more work to do in this regard.
Gladstone, thank you very much. We really appreciate your help in this area, and I know we'll love to have you back to help us address the in-hospital issues that pertain to opioids. You've done a terrific job in helping so many hospitals with their in-hospital situation.
Thank you, Dr. Denham. I appreciate being a part of this very worthwhile endeavor.
We now have Kimberly New. We will now hear from Kimberly New regarding drug diversion. Dr. McDowell had to go to surgery, however, and will not be able to answer questions at the end of the webinar, but we are asking Dr. Kimberly New to give us a quick update on drug diversion because it is such a crisis. Kim, many thanks for joining us today and giving us a quick update on drug diversion. My first question is it continuing to be as big a problem as it appears to be?
Absolutely. We've seen a tremendous actual increase in the amount of diversion that we've seen in healthcare facilities. We've also seen a lot of trends towards prescription fraud and also some continuing issues with tampering and substitution, as I've discussed with you before.
Fantastic. So what is new that you've done a wonderful job in prior webinars, and we'll put the links up and make sure that folks have a chance to come back and watch those. But what's new that we don't know, and what tips can you give us about what we should watch for now?
I can't say that it's actually new, but I can tell you what the focus is right now with facilities across the country, and that is really just putting that basic diversion program into place. Many facilities have seen that there has been an improvement in the analytics programs that are available. They're starting to implement these types of programs to be able to detect diversion, but they get the cart before the horse because they haven't actually developed a diversion response process. And that's really where we've seen a number of facilities struggle in the last 6 months to a year, detecting diversion, but then just not knowing what to do next. So I can't emphasize enough that it's really important to have that response process in place, particularly as there are improved tools now available to facilities to detect diversion. You really have to be prepared to handle it appropriately and understand that it is a staff safety risk, it is a patient safety risk, and all of those considerations need to be on the table before you really are able to effectively address diversion.
Great. Last question. The article that we put up as a slide for this discussion talked about comments you made about the escalation of the behaviors. Can you just give us a quick snapshot of how a diverter gets started and kind of where they end up or how they progress?
Sure. Oftentimes what we hear most often is that someone had some personal factor that caused them to steal a medication for the first time. And continuously we hear this is a very slippery slope, that there was never any intention to do it more than once. But once they're able to cross that threshold, it's very difficult to go back. And so what we do see is that people oftentimes do escalate over time. That's one of the things we look for when we're trying to determine whether someone has just simply poor practice and maybe poor documentation versus actual diversion. We're always looking for that escalation factor. Many times what we do also see is that people are trying to stop. And so we may see them escalate and taper off, and then escalate and taper off. But if you look at the overall pattern over a course of months, you see a definite line upwards with the escalation. With anesthesia providers, it's different. We oftentimes see them escalating very, very quickly. They're using medications that are very, very strong, and we oftentimes see that they do escalate much more quickly than for instance, a staff nurse who may be abusing a Percocet.
Gotcha. Well, listen, we'd love to have you come back in the months to come. We know this is just a daunting problem, and there are all kinds of new innovative ways to tackle things and kind of monitor it. Kim, many thanks for your help in the prior webinars, and we'll make sure that folks have an opportunity to go back and watch them.
Thank you.
Next, we have a quick update on the Vanderbilt case that we've been covering. And for those that have not been covering it or are aware of it, you can go back to listen to our webinars where they've been covered more in detail. We'll ask David Marx to just give us a quick update. He is the Just Culture leader, innovator, and founder. He is both an engineer, a former aerospace engineer, and a JD. So we'll go ahead and roll the tape regarding David Marx. Yes. So, David, we know the case at Vanderbilt is evolving. What do we know thus far?
Yeah, Chuck, the case is heading toward trial. As you know, Redonda Botz was the nurse who ultimately gave becuronium to a patient, Charlene Murphy, who was going through a PET scan. She was a float nurse trying to get down to the ED for a study, and was asked to stop by a PET scan and give Versed to an anti-anxiety medication to the patient. She typed in VE into a automated dispensing system as an override to try to get to the Versed. She actually clicked on the button, picked up becuronium, and then ultimately not seeing it. The question is, did she look or not? But didn't see it coming out of the dispensing system. She had the wrong drug in her hand. Didn't see it at bedside. So the prosecutor is prosecuting her for reckless homicide, which is she saw the risks that were there. She saw the risks and she chose to ignore them. It's very interesting. What we're seeing right now, though, is prior to the trial is really sort of a posturing that I think the patient safety community is saying, well, we're prosecuting a human error here, which is not really what the prosecutor is doing. The prosecutor is going after what he calls reckless homicide, so which I think most of us look in, and we don't really think Redonda's conduct rises to any kind of recklessness. Was there human error? The answer is yes, but I think the prosecutor is sort of looking beyond that. So I think the issue is going to play out is ultimately will the prosecutor be able to show that she was reckless? And I think that's where they're probably going to have a hard time.
Great. So we know it's evolving, but what can we learn from this case thus far as we apply your great concept and work in Just Culture?
Yeah, that's a great thing because, you know, in the patient safety community, we are very sensitive to prosecuting people for making mistakes, and I think hopefully we're pushing beyond that particular place. And again, I don't think that's not really what Redonda's case is about. But the issue, was she reckless? You know, were these behaviors that she was doing all along, not confirming the drugs from a dispensing system? I think there's a lot to learn about sort of the behavioral norms, that sort of normalization of deviance, the drift that you and I as human beings engage in. That's the real issue in this case, and that's where the prosecutor is going to be focusing is did she make choices where she knew she was putting her patient in harm's way, or simply was this sort of drift? And I think for the hospital as a whole, what was their accountability and responsibility for that? And then ultimately, just as an individual nurse, you know, what was Redonda's responsibility? And I think this will be a good case to really sort of push beyond error to what were behavioral norms and how we as a society are going to address those. I think that's what will really come out of this case is what they perceive to be Redonda's choices along the way.
Final question. Is there anything we can learn from the behavior, or at least what's been reported as the behavior of the organization? Because we know that there's a lot of chatter about the organization itself. Is there much we can learn from what's been reported to date?
Yeah, Chuck, I don't want to venture out too far there because I haven't seen directly what Vanderbilt has done. As you know, CMS did a report, talked about some of the organizational issues in this. I think what we can learn, though, is if drift is sort of a normal human behavior, did Vanderbilt do what they needed to do to detect it and correct it before patient was harmed? So I think those are going to be the issues for every institution. Is how do you really respond to how do you respond to that predictable drift? And I think in the end of this, we'll see sort of what Vanderbilt really did have in place.
Well, great. Listen, thank you very much for your analysis. We're drawing our audience to the attention of your full document, and we look forward to hearing more from you to learn from these and the other cases, because they're so important to protect those we serve and those who serve and the community at large. So, David, thank you for your great work, and thanks for the quick update.
Thank you so much, Chuck.
So the document that you saw before you with David Marx speaking will be posted on the website so that can be downloaded. There's also another excellent article by ISMP, which I have up on the screen now, which is slide 87, which has another good deep dive assessment. Again, an ongoing case, but a terrific opportunity for us to learn from. The next slide just reminds us regarding the Healthcare Innocence Project, an initiative that we're partnering in to help focus on helping use the documentation and what we call red cover reports in collaboration with John Nance that can be undertaken to really help correct things when things get out of hand, when stories are exaggerated or developed with very little information. And the concept of mobbing is kind of is described by Duffy and Sperry to be unethical communication, disparaging information that harms victims. It includes individual dynamics, group dynamics, and organizational dynamics. And so this is an area that will be covered to focus on that. We're right on time. For the last half hour of the webinar, we're going to address the issue of the mass casualty topics, and we're so grateful to have two great leaders to speak. The Med Tac program was co-founded 3 years ago, and there are 3 Campus Safety Magazine articles that 2 that have come out and 1 that will come out shortly. First on bystander care, what to do within the first 10 minutes before first responders arrive. The second was a commentary that we did on the report by the New England Journal of Medicine regarding healthcare issues, and then the third will be coming out shortly, and it's applying the concept of rapid response teams to battle failure to rescue. And this will be coming out in the next few months in Campus Safety Magazine that goes to security leaders of hospitals, universities, and faith-based organizations. And Dr. Botz, myself, and Chief Adcox are all core authors of these articles. We also have 2 more in the pipeline, one on anaphylaxis and another on dealing with surge events. But it's my pleasure now to introduce and reintroduce Dr. Gregory Botz, who's a professor of the Department of Critical Care in the Division of Anesthesiology at UT and the MD Anderson Cancer Center. He also has an adjunct faculty appointment at Stanford and is one of my heroes, as is Chief Adcox, who are both such champions of helping those we serve, those who serve, and the community at large. Chief Adcox is the Chief Security Officer and Chief of Police for the University of Texas MD Anderson Cancer Center, and they both are going to share with us, and I'll be advancing the slides for them, they'll be sharing with us an update on mass casualty issues and the lessons learned here in the recent months regarding these prior issues. Gentlemen, please take it away.
Well, thank you, Dr. Denham. This first slide here represents the beginning of the latest FBI report on active shooter incidents. And basically the graphic is just showing the states and actually the number of shootings or active shooters in those states. But I think the key here in this slide, and I think it's important for us all to remember, is that they're advocating that all the citizens be trained on active shooter. And of course, as we all know, the run, hide, fight is the most recognized approach to training for individuals. However, as we'll talk about a little bit, the New England Journal of Medicine article that came out recently, it recommended an alternative approach. And they're saying, particularly in healthcare environments, so they're talking about secure, preserve, and fight. And so basically, in short, what that means is secure the location, preserve the life of your patient and of yourself, and then fight only if it's necessary. And they sort of break it out a little bit more. So in specific areas and locations of hospitals, that's what they're really talking about. It could be your ICU, your operating room, things of that nature. So in the next slide, this is just a slide that talks about by the numbers of the 27 incidents in the 16 states. But I'd like to point out here, when you're thinking of active shooters, is of the numbers, if you look at it, there's 10 that committed suicide, 4 were killed by police, and basically all but 1 were eventually apprehended there by the police. What this really shows is that active shooters come in with a limited plan. Normally, they don't have an escape plan, and whenever their plans are disrupted, they either commit suicide or they get into a shootout with the police and are actually captured. But the basic thing is they come in, they don't have a plan other than to just reap a bunch of carnage. Slide 3, we wanted to talk a little bit about the recent article that came out, or the update that came out on the Pulse nightclub. If you all remember, this is basically showing that the Pulse nightclub, which is what can happen in a very crowded, confined area, in which 49 individuals were killed in this horrible tragedy. If you go to the next slide. So what we're talking about here and they're really critical about this, and so if we think about the way that active shooter responses has evolved over time, originally when you go back 20 years to the date today of Columbine, the police would come to the location, they would secure the perimeter and wait on the special weapons and tactics team to come and then go in. And at that same time, your EMS and fire department would then stage in a casualty collection or a warm zone. Then from there, we evolved to where we developed contact teams. So then whenever there was an incident, the police would show up, they would go to an entry point, they would stage there, the 2 or 4 person teams, they'd get all the necessary intelligence, and then they'd go in. So they wouldn't be waiting on SWAT. Well, EMS and fire department, again, they were staged, ready to go at a safe area. Then that evolved to where, for the police department, it was, first arrive, you go directly to where the last known threat is and try to neutralize the threat. And again, the EMS was staged and ready to go in a specific area. But at the Aurora Theater shooting in Colorado, when they tried to call in EMS, the people that were fleeing and the running wounded overwhelmed them, and they never were able to get in to the critically injured. And of course, they were putting the injured in police cars and rushing them off to the hospital, and it was a real mess. And from that point on is where they decided that they really needed to have greater numbers of equipment for mass casualty care involving, the different types of tourniquets and wound care items and so forth. And in this case, what they're getting critical here is that they had these vests that they had gotten, and if you'll see there, is that each vest had 10 to 15 supplies to treat 10 to 15 people, etc. And they touted it, and they worked on it, but they never did train on it. And we always advocate the promoting of a highly reliable organization. You got to have competency, currency, and proficiency. Well, obviously, in this particular report, that didn't exist, and they weren't able to get in with the right amount of equipment to try to save lives. And again, the first 10 minutes of getting the care and getting them to the hospital within 60 minutes is absolutely critical. And here, Dr. Botz is going to talk more about it, but according to some studies, that 16 additional lives could have likely been saved had this particular care been able to been brought to the scene to help some individuals. So, Greg?
So this recent article that came out in Pre-Hospital Emergency Care by the trauma group at George Washington University is really telling. We've been advocating the thought of training bystanders to provide life-saving care until EMS can arrive, but we really didn't have much in the way of data to show that would make a difference in some of our events. Empirically, we know that it's right. But in analyzing these events, they went back and looked at the Pulse nightclub shooting and looked at where the injuries were and whether those injuries were survivable based on their analytics, they showed that 16 of the people who died in the Pulse nightclub shooting could have been saved if life-saving care, including pressure on bleeding wounds, tourniquets, or wound packing had been initiated earlier. And that's really what we're focused on in Med Tac, is empowering people with the skills and the knowledge to do that until the professional responder gets by. And that's where the idea that a comprehensive strategy starting with civilian providers to provide care at the point of the event is life-saving. Our strategy for responding to these multiple casualty events is to go and stop the killing, stop the attacker first, and then start the care. And oftentimes the EMS providers, whether they're embedded with the law enforcement or whether they're in the traditional incident command model, they're many, many minutes away from reaching those people who are bleeding to death. Next slide, please. So this is looking at a profile of wounding from the same group. Where were people injured in these mass shooting events that have occurred recently? And is there an opportunity for these interventions like putting pressure on a bleeding wound or putting a tourniquet on really realistic? And again, it supports the fact that people that have gunshot wounds to the head or the torso may not be survivable, but those that have gunshot wounds to non-vital organ areas or in the extremities are clearly those that we want to target with these relatively simple skills to provide. During our Med Tac programs, we've been able to teach school-age children to put on tourniquets effectively. So we know that our audience in bystanders are able to do these things. If we give them the competencies to do it right and give them opportunities to practice it at a regular interval, there's a good chance that if an event occurs, they will rise to the occasion and do the things that need to happen in order to save many of these people who may die waiting for the traditional model of healthcare to arrive at one of these events. So our treatment strategy goes beyond the traditional mode of medical care in these emergency situations, but depends heavily on bystanders, those that are at the scene, to step up and provide life-saving care while awaiting the arrival of the professional caregivers. This is some data from the same group at George Washington looking at wounding patterns from different events that have gone on in civilian public mass shootings in the United States. I think many of us here in the news media, when these events occur, that the perpetrator has a high-powered rifle, and that's what's causing all of the death and destruction, the serious injuries to the people that are in that event. And this is looking at autopsy studies in 232 victims from 23 events. And in fact, if you look at the data, depending on where the wounding occurs, those that are shot with handguns actually have a higher mortality than those that are shot with rifles. I'm not sure why that is. This is just data demonstrating what we found from the events that have gone on. Civilian public mass shooting events with a handgun are much more lethal than those associated with the use of a rifle. So how do we approach this? How do we build a program where bystanders are the link in the chain of survival between the incident occurring and the arrival of the first responders, the professional caregivers? We know that our professional first responders are highly trained. They have the skills and equipment to do many life-saving interventions, but there still is a gap from the time of the event until their arrival where we can affect care with bystanders that can have a direct impact on the outcomes, the survival of those various events. And that may include expanding into basic airway management. So think about the opiate overdose person that is found down by a bystander whose really only chance at survival is to have some sort of artificial oxygenation until you can either deliver Narcan to reverse the respiratory depression, or someone with skills to provide artificial ventilation. Remember, opiate overdoses are not fatal from the drug. The drugs are not toxins. They cause profound respiratory depression and bradycardia, and those things with the right skills can be stopped and managed until professional lifesavers arrive. So having some basic airway management skills, simple interventions for thoracic injuries, a plan for casualty movement from the scene of the event, from a direct threat area into an indirect threat area where the likelihood of additional injuries to both the victims and the other bystanders is reduced is an important consideration. And also during those events, until the law enforcement assets have neutralized the threat and the life-saving activities of EMS take place, this is a very psychologically dangerous environment, and paying attention to the psychological comfort of the wounded and those who are in that environment both reduces the suffering, I believe, but also speaks to the ability of the bystanders to perform under very psychologically stressful circumstances. And as always, having improved communication between those who are at the scene of these events and our emergency dispatchers through 911 or through other assets, having situational awareness and effective communication to get the right assets in the right place at the right time is crucial to the survivability of these events. Okay. I think an important resource that's part of Med Tac is the preparation before any event to talk about what the group might do if something happens, if an event were to occur. So before a sporting event, before a gathering, before a school function, to gather the folks together to talk about who's going to be responsible for the key roles in the response to any medical emergency or other emergency that occurs at the scene is crucial to get the organization and the action from the group in order to provide the appropriate care. So the care huddle is a checklist that works on preparedness for events that might take place. It assigns roles for key issues that can take place. So I don't know how many of you have ever made a 911 call, but it's not a familiar thing to most people to call 911 and have a conversation about what you see and what you need. And that's why the best dispatchers use a routine of asking targeted questions in order to get the best idea of what resources are needed quickly. So practicing having a 911 call, having someone who can give the right address, the right entrance, the right location so that EMS can arrive at the right place. If you think about it, some of our big schools have multiple entrances. Even our hospitals have multiple points of entry into the hospital. I know at our institution, the address on many of the phones that call 911 all have the same phone or the same address, but it may be the north entrance or the south entrance. And so giving that information allows assets to get to the right place in the right amount of time. Having an idea of who's going to get life-saving equipment, whether that's an AED or any other first aid equipment, to the place where it's needed effectively is really a key concept, because when these medical emergencies occur, people think others are going to do it. One of our key concepts in medical emergency response in the hospital is that someone doesn't work here. So when you ask for someone to do it, everybody assumes that someone else is going to do it. You have to be very direct and assign roles so that they know that that's their responsibility in these events. These are all key behaviors that we want people to undertake in the event of an emergency in their location so that they have the best chance of getting the right response and save lives.
Yeah, and also I'd just like to add that you could not have enough first responders or EMS or fire department or other individuals to a massive casualty event. If you think about Las Vegas and all the lives that were lost and all the people that could have been saved, the bystanders out there were using their belts and they were doing everything they could. Had they been trained, had more been trained, and then you had equipment around, go bags around that were available where you could get this life-saving equipment, more lives obviously could have been saved. So being able to do that. The other thing is even in the hospital setting with some of the most renowned physicians and quality nurses, a lot of individuals just aren't practiced on and competent on mass casualty or these types of traumatic injuries. So having Med Tac type related training and having the equipment available and having a huddle tool, particularly if you're giving a program or a tour or a lecture, could be the difference between life and death.
Yeah, I tell the example. One of the organizations that I belong to is the Society of Simulation in Healthcare, and we were at a meeting in Orlando, and the keynote speaker was talking, and someone in the first row fell to the floor. And of course, the simulation population thought, well, this is a simulation of something that they're showing, but in fact, it was a real event. And in that hall, in a convention center, they couldn't find the AED, and they couldn't. The people that were there didn't know what to tell EMS other than they were at that hotel in the conference center. That's as much information as they had. At that society meeting now, at the beginning, the president of the society usually says, you know, welcome to our meeting. We're glad to have you here. And oh, by the way, the nearest AED is there. That's basically the beginning of a care huddle.
I think I'd like to jump in here, and I'll have you two gentlemen be our reactors today, as Dr. McDowell had to go to surgery, but I would love to have you all react just after I go through the survey questions. But I just want to congratulate you, Greg, for actually coming up with the concept of the care huddle. That was your invention, and it's been so amazing to train kids from third grade on up. We've trained now so many, and they really, really understand it. So very quickly, before we come back to both of you to react to each of the presentations before you, and then also things that you want to add, the survey questions, please, our audience, I would like to have our audience answer the survey questions in the right panel on the edge of your screen. And the first question is, I'm interested in another webinar presenting pain management safety issues, and what issues that you would like to have covered is in the free text entry. So if you really want us to cover it again and do a deeper dive, especially in the in-hospital setting, we're happy to do it and have Dr. McDowell and other pain and adverse drug event leaders come to speak. Give us the topics and the free text entry. The second question is workplace bullying and violence issues, and we include these mass casualty events as the worst events that can occur, but we can have a violent intruder or even have bullying and mobbing, and this whole continuum of workplace violence is just an enormous problem, and we're seeing 60% of the call-in lines, the general call-in lines for bullying are nurses. So we know we've got a big problem, and 4 to 5 times the incidence of it of other industries. We'd like to know if you'd like to have us cover more of these topics again and have some of the experts come back to speak with us, and the topics you'd like to have covered. And this would include workplace violence from others in the organization, but also from patients, especially as we consider the emergency department and your outpatient settings. And then the last is, I'm interested in another webinar on the bystander care issues. Dr. Botz and Chief Adcox covered things very briefly. We'd like to know, would you like more detail on this evolving issue of bystander care and how your organization actually can generate impact? We're seeing a lot of organizations realizing it's a great idea to have Stop the Bleed training programs for their own staff, get people trained and get them in the community. And then if you have topics that you'd like to have covered, please cover those. Gentlemen, we're right on. You've got the last 6 minutes to really react to Greg and Bill. React to what Gladstone covered, if you would, so we can just cover them in order. I know, Greg, you've got an enormous competency and a body of experience in this area, having being an anesthesiologist as well as a critical care doctor. Are there things that you'd like to underscore that Gladstone covered, and then go to Bill on drug diversion?
I think that Dr. McDowell's discussion about the strategy for pain management is so important in the care that we deliver to our patients. Having a stratified approach that doesn't depend on opiates early is probably the best way that we can address pain in our patients and allow them to have good function and reduce the risk of dependence or addiction that we see has been so much an outcome from from haphazard pain management. Having the pain score less than a certain number is not as important as having a strategy to understand the physiology and the pharmacology that needs to be put in place to address acute and chronic pain.
Thank you. And Bill, do you want to react to the drug diversion issue, and then back to you, Greg, on it, because I think you may also have some insights there.
Yeah, I think Kimberly New was spot on. I think my issue is to make sure that you study the issue, you have a very professional approach, you bring in individuals like herself and others that can help you set up a very comprehensive program that definitely is based on the threat safety principles of threat management, multidisciplinary, cross-cultural type of groups that are participating. But the ultimate goal is that you never push the diverter actually to the patient. And I think that's the most critical thing to think about is with drug diversion is if you're not really good at what you're doing and you don't know what you're doing, you can very easily push the diverter all the way to the patient and cause great harm. So, Greg?
I think this is a particularly important focus for us on diversion. Drug diversion is an occupational hazard for healthcare providers. And of all of the safeguards that we have in place to try to keep control of our controlled substances, there are many workarounds. The person who's seeking to divert these drugs have a very strong will and a very strong conviction to do so, and it may defeat some of our strategies, but we have to be able to recognize drug diversion to prevent a serious injury to our healthcare providers. As I've said on this webinar before, I'm an anesthesiologist. I practice in the operating room and in the intensive care unit, and over my career, I've lost 5 close colleagues to opioid doses, and I had no idea, none whatsoever, that they were using. I didn't have an opportunity to intervene.
Yeah, and also we've lost 2 nurses in the last 2 years at UT System Hospital, not MD Anderson Cancer Center, but at UT System Hospital. And I think the thing that I'd like to remind individuals is it's not something that individuals can easily identify a person that would be using. And matter of fact, usually that's your very best employees. They need to be at work. They're going to work overtime. They need to have access to the drug. And basically they're just using it to be able to maintain. So you're not. It's not the same as if you were to catch a person that's driving under the influence, and they're going to be shaky and slurring and walking funny. That's the absolute opposite of a drug diverter. So you have to be real careful with your program, know what you're doing.
Well, and when I finished recording Kimberly, and we were off of the recording, I said, we're seeing articles coming out about nurses that are passing away or physicians that pass away at their own institution in the bathroom. And she said, absolutely. And I think all of us need to be prepared, as you've taught us, Greg, to be prepared to use Narcan and in our own institutions. This is happening more and more frequently. And how frequently do we have Narcan in the lobby? We described one case where a nurse had gone into the front lobby of the hospital and then no one found her right away. Greg, any thoughts there? Yeah,
that's so true. I think that's one of the key reasons why we have law enforcement, our UT police officers carry Narcan, because they are out of public areas. They're likely to respond when called for some of these things. And our goal is to get the right treatment and the right help to someone so that we don't have a fatality. It's so true. They aren't using these drugs in their work environment where someone sees them. It's always secretive, and if we're not able to find them, usually they're found dead, and that's not the outcome we're looking for.
Well, listen, we're right on time, and I am so grateful to you, Greg, for inspiring us to start the Med Tac program, and for Chief, you to be constantly supportive, co-leading it, and really bringing such an enormous body of experience and the whole security and law enforcement and de-escalation and the state-of-the-art that you're practicing as one of our global leaders in threat safety science. We're grateful to both of you. I think we have Jennifer Denham had a healthcare emergency in her family, but she was able to record a close. Kyle, could you record that? And we thank you all for your attention.
Well, this was quite a webinar. Thank everyone so very much for everything. And again, I encourage everyone here to please share the recording with your colleagues. Thank you so much for being here and looking forward to future webinars with everyone. Have a wonderful holiday and God bless you all.
Thank you, and that closes our webinar for today.